So we asked them to come and join us, and we would walk them through this design thinking process, one that IDEO uses almost exclusively, and also to see if we could help them move their ideas along significantly. So the teams that proposed the design challenges were then matched up with anybody who was interested who applied to be part of this workshop, and we created teams of 5 and 6 people who in most cases had never met each other, didn't really know what was going on, and then we asked them to collaborate and actually make hay, do something interesting, and see if they could actually progress their ideas. And I'm happy to report that across the board, we were extremely impressed at the level of collaboration and the teamwork and the output from that. So what you're going to see today, during this session, then, is the report out from each of those 8 design challenge teams. You're going to hear what their original ideas were, what they worked on, how they advanced their ideas. And importantly, at the end, the reason you have clickers is to, you're going to help us choose, actually, ones that you think were really compelling. We have a couple questions to ask you, and the last of which is going to determine which 4 teams get a chance to come back and present their findings as part of the open access journal. That's a function of this conference. So I'm not going to talk much more, and I'm going to let the teams present what they learned. So just as a reminder to the teams, you have a strict 7 minutes. We'll give you a reminder at 6 minutes that you have a minute left. Have fun.
Hello, everyone. My name is Ronnie Wren, and this is my team. We are presenting on advancing efficiency and efficacy of modern stroke rehabilitation. Lower limb hemiparesis post-stroke will rob a man of his ability to walk. This is not only debilitating physically, but emotionally as well. That's why it is crucial for us to be able to offer effective physical therapy that will not only encourage neuroplasticity in acute and chronic setting to most effectively restore his ability to walk. The problem is that the patient actually only spends about 13% of his waking hours actually in physical therapy, while spending 50% of his time just being completely inactive. Why is this? The reason simply is because we don't have enough physical therapists. That's why we need to develop a solution that will be able to effectively take advantage of the patient's idle time with limited manpower. Initially, we designed exoskeleton to solve this problem. While we addressed several issues that we had to deal with in rehabilitation, we also faced several barriers. For one, it was too expensive, it was complex, and it was bulky. It was just very difficult to implement. We need to simply come up with something that was better. In developing our new model, we considered these factors to be most important. For one, it had to take advantage of the idle time that the patient had while with limited manpower. 2, it had to encourage neuroplasticity of the brain through active physical therapy so that he could most effectively restore his previous limb functions. And 3, it has to maintain his motivation to continue with physical therapy, because physical therapy is a very difficult and challenging process. So what we eventually came up with was a novel rehabilitation device that adapts therapy according to the patient's progress. Now, for those of you who don't understand what a stroke is, oftentimes when a stroke occurs, a patient will suffer one-sided paralysis. So what our device actually does is that it will leverage the healthier limb to support the movement of the affected limb. And as the patient recovers, this device will sense that and adapt its therapy according to his current level of function. So let's take Bob here. He recently suffered a massive stroke, and he now is bedridden and cannot walk. His physical therapist will come and introduce him to our device, which in this case, the pedaling system that will help him restore the function of his legs. So what's going to happen is, if you want to demonstrate, his stronger leg is going to support the movement of his weaker leg, and his weaker leg will initially just passively move along, just following the regular motions of walking in order to relearn it. Eventually, his weaker leg will start to regain its function, start to regain its strength, and this device will sense that. And basically, it will decouple the two sides so to actively force and actively encourage the weak recovering side to move more actively and move independently. The end goal of this is eventually the patient will regain function enough and regain his strength enough to be able to walk on his own outside of the hospital. Now, along with this, we'll also have a user interface that will feature a variety of things like games, virtual networks, tracking progress. These things will keep the patient motivated, and it will keep the patient cognitively challenged. And this doesn't just stays in the hospital. When the patient will get discharged, this is easily producible enough to be able to be brought home. So the patient can continue his physical therapy at home while taking advantage of the various softwares that we can offer to maintain his motivation and to keep making progress in his recovery toward walking again. So using the IDEO method, we came up with a device that will reduce caretaker burden on post-stroke care, maximize patient recovery, maintain patient motivation while being cost-effective. Thank you very much.
So hi, my name is Doug. I worked with Jillian and Shannon and Colas to develop the Symphony EG, a mind interface for music and music therapy. So the clinical need we're trying to address here is that patients with chronic pain and emotional disorders can greatly benefit from music and meditation therapy. But embarrassment from public use of devices that are meant to be therapeutic decreases compliance with these patients, and then they don't get any benefit from things that would otherwise provide them with great help. So the solution we're trying to come up with here is a device that users want to wear, even if they don't need it. And so what this project evolved out of was a pretty amorphous original thought. The idea that brain-machine interfaces, or BMIs, can be used to control mobile devices, but that hasn't been implemented to date in a really usable or utilitarian manner. And the critical insight of this project in this workshop was that we can help treat a great deal of clinical needs with this type of product, but only if patients want to comply. And so once we identified that, we started breaking down how we can use this device both from a clinical point of view and from a compliance point of view, getting people to want to wear it, even if they're not a patient. And so Jillian's going to show you the prototype that we came up with to solve this issue.
Hi, guys. I'm just going to move that slightly. All right, so I'm just going to go over the prototype. First, introduce how our device is actually going to work. It's through neural signal acquisition, through electroencephalograms or EEGs. And so you can see in our prototype that we have 6 electrodes. We can use 6 to 8 electrodes in the device to capture real-time brain activity to provide feedback to the software to be continuously monitoring. And so through adaptive analysis, the software uses machine learning to provide a very personalized user experience. Because what the machine learning does is it interprets how the therapies are working with each specific patient and how each therapy is working, and it adapts the therapies as needed and makes them better for that patient. And so, as you can see from my device, it's a private experience. The bone conduction speakers actually provide private auditory feedback and music without any way for others to tell that you're actually receiving auditory input. And because your ears are not covered, you're actually free to have input from the rest of the world and to interact with the rest of the world without anyone knowing that you're actually receiving input.
But this device isn't just for patients, it's for everyone. And it can provide a unique and convenient music experience for anyone who wants to listen to music in a better way than they have before. And so I'll hand that over to her now that she's set up the device.
Set up the device. So as you can see from my transformation, there's actually over-the-ear attachments that can be added onto the device. So they act as noise-canceling headphones when the user wants to be listening to music without any interaction from the rest of the world. And so you can easily add these on and then take them off again. So you have the noise-canceling headphones when you want to just listen to music, and then the bone conduction speakers when you just want to be receiving input from the device. And so with these noise-canceling headphones, this means hands-free and sight-free control of applications such as Pandora and other music players without even having to take your phone out of your pocket, without having to look at your screen. And so what this also means is that for patients and non-patients alike, it's music for any mood. Because although music therapy is the clinical application of this device, it can also, the EEG signals can also provide feedback for the software to create playlists tailored to any mood that the user wants to put themselves in. For example, if you want to be in a relaxed mood, the machine learning algorithm will remember which songs best do that for you specifically. So, hand it back over to Doug.
So we wanted to look at a very specific use case to see how this type of interface would work. And we looked at the application Pandora. We wanted to work within the constraints of current open source technologies to make sure that this is easy to develop. And those have the capabilities to definitely produce at least 5 unique neural inputs from a simple EEG signal. And so we broke the Pandora application down into a simple interface that can be done, but just by thinking up, down, left, right, or focusing. And with this interface that we created, this first prototype, you can actually access every function of Pandora in a simple and easy to use interface without having to use your hands or your voice. This is the old one. But, so the next steps of this that we want to do is to create first an aesthetic but non-functional prototype, and wear that around to see how that affects users' experiences and see how you can really wear this in public and see if this is okay. And we're also going to create a simple functional prototype to start to look at how users interact with that type of interface and how we want to build that interface. And the lessons that we've learned from this is that this is really a viable product. Through open source technologies, there's a clear path to a quick development. And there's clear early adopters here as well. Physicians trying to provide pain management for chronic pain patients and for patients with emotional disorders really need new technologies and new options to give their patients better treatment. And techies who are just into new technology, new music options, are also going to want this type of product as well. And furthermore, we've also identified a number of large addressable markets that we can eventually expand to. On the clinical side, everything from emergency notification automatically. And then on the consumer side, everything up to being able to control your environment with your mood in producing the environment that you want with just how you feel. And so that is Symphony EG. Thank you.
Okay. Our team, Diana, KP, Chen, and Fabiano, and myself, Hermano. This, first of all, it's not a new idea. It's a patent technology that we licensed. And it's basically a new way to assess gastrointestinal tract physiology. There are 2 big markets here. The first market is research, and I'm highlighting here animal research, which is the largest chunk of it, which is a $1 billion market. Unlike many medical device projects where the medical application overwhelms the research market. This is very different. Today, we're in the dark ages on animal research. We have a sanguinary process because the animals have to be sacrificed after every single experiment, and extremely complex and difficult to replicate. On the human side, it's expensive. The gold standard is gamma scintigraphy. It's a $1 million camera that very few hospitals can afford. Intimidating to the patient because they need to ingest a radioisotope to do this, and expensive. We came here yesterday morning with an original design challenge that was extremely ambitious and unrealistic, of making it functional, affordable, and user-friendly. And the IDEO process made us evolve on that. But before that, I just want to show you this is where we are today with the technology. As I said, it's a reality. This is not an idea. And on the right side here, you have an illustration of a real image created of the food passing from the stomach to the lower GI tract. At time 0, all in the stomach, 1 hour, 2 hours, 3 hours, 4 hours. The food is now residing in the lower GI tract, which is a normal behavior for an animal or the human. Okay? We started the IDEO process with this concept, and one of the things I would highlight is that we're taking a very different approach to the animal research and the human diagnosis. When we had the brainstorm session, and one of the groups worked with us here, and we had all these outsiders to the project help us, it shifted our mindset quite a bit. And we realized that there was a lot of commonality of needs on both projects. So this was a terrific exercise for us. And another thing we learned is that we would be much better off if we split the whole process here in two parts. One that could be handled by a lower skill operator, and leave the critical tasks of the investigator and the clinician separate to that. And how did we do that? Our main idea came from a very simple concept. We thought about a coffee maker. Anyone can make coffee, a coffee maker like that, right? So we designed our little rat scan here, which is simply, there's some very important parts to it. There's a cassette. The rat goes in. The position of the rat is very important, so a cassette is made for it. Goes in here, and this basically takes a picture of it. There's just a push button here that anyone should be able to do. And that takes away a lot of the complexity of what today is available. Here's the whole system working. We have the low-skilled operator at the start, does the animal preparation, pushes the button, the image is generated, goes to the cloud, comes to the clinician or the investigator anywhere in the globe. So the analysis and the diagnostics can be done remote in the case. So here we have radiation-free, non-invasive, easy to perform, affordable, applies to research and diagnostics, and no more guillotines. In addition, our next steps here. We are basically 1 year away of putting in the market the first small animals device, and to have a human prototype, a workable human prototype. What we need basically is, like I said, we have the technology, we have the experience in doing this, we need additional funds. We already have funds, we need more support on that side. Oh, and in next steps, tomorrow we're meeting with the company, an engineering company in the outskirts of Houston, and that's another reason we came here, to talk about and contract the design of our prototype. And why we're doing that is because this company has a history of being very careful of, from day zero, consider the FDA requirements, so we are not penalized later on in the process when we're ready to do medical products. So, and they have a long history and very good capabilities to do that for us. That's what I have.
So hi everyone, good afternoon. We are the TransView team, and our prototype is a device that helps surgeons see inside the patient during a surgery in a way they never could before. So first, a little bit about the context. What you see here on the left is an angio suite, and you have an interventional radiologist that is performing a minimally invasive procedure. What that means is they insert a catheter in the groin of the patient, and they essentially go blind. They're inserting surgical instrument through that catheter without really knowing where they are in the human body. Now, there's one thing that helps them is there is an X-ray machine called a fluoroscopy machine that does take images once in a while. The IR can press the pedal. And this is the kind, this is the kind of image you see on the bottom that they get. So it's a 2D plane, it's a projection. As you can see, there's the spine here, and this is the catheter. Now the issue is they don't know exactly what depth they're in the body. So they don't know, for example, if they're inside the vessel or outside the vessel. So this is why we say that they essentially go mostly blind. So this is the main need that we were trying to solve, is how do you augment their vision so they can actually see inside the body. Now, interestingly, through the IDEO methodology, we went even beyond that. So we started brainstorming and realized there's an opportunity to not just see inside the body, but also project information onto the body during the surgery. We also realized that you can go beyond just looking at images. You can add other types of sensors. So temperature and pressure can add a lot of information, as my colleagues will tell you in a minute. And then finally, we realized you can actually get some feedback, so you can know as you're hitting the wall of something, the catheter can shake, and so you can get some of that information as well. So it becomes sort of a full immersive experience for the surgeon. Now, another need, a critical need, is that these X-ray machines obviously give you radiation, both to the patient but to the radiologist as well. So they actually have to wear these pretty heavy apron that hurts their back. So our device could get rid of that fluoroscopy because we're now working with ultrasound, which means that you no longer have radiation. And if the IR surgeon wants to still wear an apron, they can keep it to the kitchen, like Charlie Sheen. So now you'll hear from our IR and resident doc about the technology.
Okay, so we initially chose a specific procedure to sort of frame the problem, and that was the transjugular intrahepatic portosystemic shunt. So in this procedure, you basically need to create a conduit from the hepatic vein to the portal venous system. And typically what happens is you see your catheter, you sort of know it's in the hepatic vein, but you can't really, you can't tell where the liver parenchyma is here, so it's kind of a blind stab, and you're just sending a needle from one and hoping that you make it to the portal venous system. So the idea was that we would create an ultrasound guide catheter. So we already have a catheter in place, and what we would do is use a capacitive micromachine ultrasound transducer technology, uses photolithography and dry etching to create a transducer array, a ring array on the tip of the catheter, and give you a forward-looking image. So then the idea would be that instead of having an image like this, you now have an ultrasound image. The image is coming from your catheter tip. You can see the vessel, that's your target. You can see your needle, and you go straight forward.
So the IDEO methods and having a really great team helped us identify what was good about our previously existing design concepts. And from there, we were able to build upon those to create something that really is valuable. So we used the how might we questions in the brainstorming session to find 2 questions which would help us develop and improve our design. And firstly, we were able to think about sensors to add on to our design that would be valuable to the physician. And from there, we were also able to broaden our device applications so that it would be useful in a wider range of procedures.
So we basically took the existing CMUT design that was previously used, and simply made simple modifications to incorporate the thermal sensors and also the piezoelectric pressure transducers as well too. And like as it was mentioned earlier, the reasons for these was because it's great to have an image as we're going down the vessel, but there's so much more info that you can gain throughout the effort. For example, if you encounter a bend, if you're putting a lot of force into the push, and you could, depending on the force, damage the vessel wall and all that. So it was important to gain as much info so that the operator of the device can have the feedback and be aware of what is going on. So we used that to build our prototype, and it's essentially a catheter which has a large lumen throughout the center that you could pass this guide wire through it. And so at the very tip is where we have all of our sensing technology. So we have the ultrasonic, the pressure, and the thermal sensors. Down the length of it is where we would have to pass the wires that we would receive the data from, and all that will be integrated into the hub, where we would interface with the software. And one of the benefits of having the pressure information is that we can also incorporate a force feedback component into the hub, so that depending on the amount of force at a threshold, the user can be informed of the amount of force he's inputting into the vessel.
Okay. So the fact that a lot of that these catheters are being fed almost blindly is really problematic. And so with just a little bit of imaging and a whole lot of medical intuition, physicians are really supposed to avoid creating a dissection of any sort of veins or arteries that they're investigating. Now, our thought is if we're kind of already introducing this new disruptive innovation of ultrasound catheters, then why don't we leverage that to create a more wholesome and beneficial user experience? And so the idea that we came up with was actually a sheath that goes over the limb that's being investigated that doesn't actually interfere with any of the sterile practices. All right, and so the underlying concept is that there's two sides of the sheet. The underside is an array of ultrasound receivers, so it's actually coupling with the tip of the catheter, right? And it actually locates the position of that catheter at any given time. And on the surface, there's a silver screen which actually projects the ultrasound image of the forward and bilateral views. And so our visualization of this kind of mock-up OR from the perspective of the interventional radiologist is we have this kind of haptic feedback catheter, right? And then also a laser which actually pinpoints where on that image the tip of the catheter is. So it gives it much more global visualization of where you're feeding this wire. Right, and this is just a little demonstration of how this would be used in action. So we see here's the underside with the array, the ultrasound array.
Is music supposed to be playing?
It doesn't matter. But, and then on the top, we see this visualization of the vasculature underneath, right? So that we actually have this very well-defined visual interpretation of where we are, and we're not doing it blindly anymore. And here's this schematic of a laser which is being projected down. And so just to strengthen the visuals, we have something like this, where we're trying to give the user both frontal and bilateral view of the anatomy underneath, right? And so we have this laser and a visual based upon the ultrasound, right, to actually mark up where we are in the leg.
The feedback that's going to be provided to the physician will include a screen with the 3D real-time in the vessel view. And then we'll also have our temperature and pressure sensors graphed. And you can see the threshold over which the pressure sensor, if it passes, will provide that vibration feedback to the physician so that they don't puncture the vessel walls.
Okay, just sort of looking forward really quickly to finish up. This doesn't have to be just interventional radiology. There are many stakeholders involved. In cardiovascular imaging, we usually see the outline of the vessel. We try to infer that what's going on. With ultrasound, you can see the plaque. You can see the fat in the plaque. You can characterize masses. You see the borders of the masses, so you can follow treatment when you're doing ablation, for instance. In bronchoscopy, people have an optical view. They can't see beyond the wall. With ultrasound, you can sample lymph nodes. And in colonoscopy, again, you can see the depth of the lesion. And then finally, with ultrasound, we can probably change the whole paradigm. You have these angio suites, the patient is here, large technology, major installation, there's nowhere for the person to stand. But why not, with this kind of comprehensive imaging system, have a whole new type of OR suite, something that's wide open, easily installed, has many stakeholders that can get involved. Why not have it with such a comprehensive system? Thanks for your attention.
Thanks, guys.
Thanks so much for having our team. Thanks to IEEE for bringing IDEO into this process, or for IDEO to pitching IEEE, or however that worked out. It was great for the rest of us to be part of this, this neat design challenge. And team is James, Shandy, and Paul, and actually everybody in that room I kind of considered part of the team in the early stages of the IDEO process. Everyone was just throwing stuff against the wall, and it really made your thinking fold into entirely new places. And it's hard for some of us that have been working on these ideas for a long time. So I'm glad I didn't get voted off the island early on. But it's good that everyone really acted as a team player in the process. So our project is the point-of-care newborn heart imaging project. Oh, wait, I need to do this, right?
instead of you. Or wait. There you go. Okay, cool. So here's our design challenge. A significant number of babies in the U.S., tens of thousands actually, that are born with congenital heart disease. It is the most prevalent birth defect and a major killer of babies, actually. And we have a huge issue with prenatal diagnosis still in this country. Less than 50% in rural and outlying areas. That number actually falls closer to 25%. I live in Minnesota, so we have a huge state. Texas, same thing, lots of outlying areas where that prenatal detection rate is very low, a little bit higher in metropolitan areas. But the point is, 20,000 of these babies in the U.S. are coming out of the womb with congenital heart disease that is undiagnosed. And a third of those babies run the risk of delayed or misdiagnosis after the newborn nursery. So interestingly enough, our family fell into sort of all three of these categories. Our baby Eve, up at the top, was 1 in 100, so she was one of those 40,000 babies. She was not diagnosed prenatally. She was diagnosed at 3 days of age, really as our bags were packed and ready to leave the hospital. And so technically, we would have been a missed diagnosis. We just had the stars align, and we got incredibly lucky. So this is about the size of a newborn heart. Our daughter's heart was 3 times this size. And they did her echo at 3 days old. She was in heart failure, completely asymptomatic, other than a mild murmur. So where we're trying to go here is to improve outcomes through early detection of congenital heart disease. We've got a domestic use case for this, and that is that in 2009 we started a pilot in Minnesota using pulse oximetry to screen newborns to help earlier detect hypoxemia, and that led to sort of a process that I pursued at the federal level to get critical congenital heart disease nominated as a condition for the routine uniform screening panel. So all the blood spot screenings that they do for babies, it's called the RUSP. The only other thing that they screen for that's not a blood spot screening for newborns is hearing screening. So it was a little bit novel. It's the first time we'd screened for a birth defect, but the good news is in 2010, that committee did actually vote to recommend all newborns in the United States be screened for heart disease. So that's 4.1 million babies that are now gonna have a pulse oximetry screening, and hopefully will up our chances of knowing that there's something else we need to do diagnostically to confirm whatever that cause of hypoxemia is. This is where a simple, rapid, scalable imaging technology comes into play. The issue is this sort of technology is simply not available. We have babies being born at 6,000 hospitals and birthing centers across the country. Only 3%, 3.5% at best, have specialty pediatric cardiac care, meaning they have pediatric cardiologists, echo techs, cardiac surgeons. So that's a huge disparity, and these kids are just universally being transported regardless of what we know about their condition. So what we're trying to do is have a tool with caregivers with limited skills in those low-resource community hospitals and rural and underserved settings that they can use to determine what sort of status the baby's heart might be in if they have symptoms or if they failed their screening. So this is where we sort of started, was a diagnostic pathway for these kids, utilizing kind of standard echo probes made for neonates, something that would plug and play with off-the-shelf tablets, trying to get us away from the big sort of $300,000 echo carts that are available in most hospitals, but not all, and then ported imaging software. This really evolved through the process, and that was with the team kind of and our co-team members out in the audience throwing a lot of ideas at us, which was great. So we actually have a directive out of that Secretary Sebelius recommendation to develop this technology. It simply doesn't exist for these failed screens. Like, what are you gonna do with them in outlying areas? So we furthered the idea by trying to eliminate the handheld probe. That gets rid of the idea of like, this is a technician doing Eve, she knows what she's doing. She's been an echo tech for 15 years. She knows exactly how to place that probe, exactly how to acquire images on a tiny heart, and exactly how to acquire images on a heart that has a congenital anomaly, which of course adult technicians are not used to seeing. So we've got standardized echo transducers in our
technology that can be scalable and improve. We could start out pretty rudimentary and improve that as we go along, and then blend with existing capabilities, existing hardware for those places that do have that $300,000 Echo Cart, but a standalone data acquisition tool for the places that don't, so it can store and transmit as needed. So here's what we came up with. We called it the whoosh because that's what it sounds like. If you've ever heard an echo, either a baby ultrasound or a heart echo, it's that whoosh, whoosh, whoosh. So it hyper simplifies the data acquisition, and what we sort of needed was a baby to test model this on. So this is Maybelline. She's my fourth, easiest delivery. Yeah. And she's about the same heft as an actual newborn. This is about what Eve was at, about 6 pounds. And this is actually my cosmetic bag, so that's why she's called Maybelline. It's full of all my makeup, so it should borrow someone else's lipstick. And that's my sign that we need to be almost done. But what we're going to be doing with her is when she comes in, she's at a hospital 100 miles from Houston. She's failed her pulse ox screening. She's going to come in to the primary care doctor, who's been called in by the nurse, and they're going to be able to put this almost band-like transducer switch. It's adhesive, so it's not going to move around when we put it on the baby, so much like an EKG patch. But it's going to be able to get everything that's sort of required to make a rudimentary decision about what sort of status the baby's heart is in. Simple, three-pronged, red, yellow, green, and hopefully that's going to get us to the next step, which I'm going to let James really quickly talk about.
So we have 3 different scenarios that we're envisioning when the baby's out of the hospital. So the baby's been at home for 3 days. Baby turns blue. Mom and dad freak out. Babies aren't supposed to be blue. We get them in the car. We rush to ER. Triage. Nurse takes a look. Takes the device. Whoosh. The information is sent to the monitor nearby by Bluetooth, and we call in a cardiologist. Second scenario, we're 200 miles from the nearest sick kids hospital. We're on the highway. We call 911 because the baby's blue. What happens? They send out a paramedic. Paramedic rig shows up. The paramedic takes the device, puts on the baby, whoosh. We find out the red code. They call in to the nearest sick kids hospital. They fly in an air ambulance. We get the baby to hospital right away. Third case, 1 weekend, we go to the GP for the regular checkup. We know what those checkups are like. The GP, not a cardiologist, not a specialist, but has a suspicion that something's wrong. Takes the device, puts it on, whoosh, red. Calls up the sick kids hospital down the street. They send a paramedic, bring the kid to the hospital.
Great. Okay, I've officially decided James should have done this whole presentation. So here we are, next steps. We need to do some clinical field research. I've done about 2.5 years of research with the clinical teams and engineering specialists on developing what was our original thought process. So we've got some great data, but we need to figure out whether this simple layover transducer patch would work, and what type of materials, et cetera. Early stage test pilots would be awesome. We're looking at the need for partner funding to be able to advance any and all of that. And our goal would be to implement as soon as possible in underserved communities with our domestic use case, and in certain mid-tier developing countries that would be ready for this sort of thing. A standard of care, much like we did for pulse oximetry, would be great. This is Eve today. She's obviously doing fantastic, thanks to early detection of heart disease. Please keep in mind that in the short period of time that we've been here listening to all these great presentations, that 3 babies have died from congenital heart disease right here in the US in the last 90 minutes. One of those was a preventable death. Thanks so much for your time.
I'm Larry Beatty with the Phoenix Project, which is based in Minneapolis, Minnesota. We work with the Chronobiology Center at the University of Minnesota, and also with the Electrical Engineering Department there. The team here, we have Vijay, Mohammed, and Shalala, and Adaro, who has gone home already to deal with a family emergency. I hope almost everybody here knows, well, I hope everybody here knows that stroke and cardiac disease are real problems in the United States. You can find all sorts of numbers. You might not know the specific numbers, such as a third of the deaths in the United States, according to the CDC, are actually coming from these problems. And that they're labeled number 1 killer, number 2 killer, number 3 killer, depending on which year it is and which exact statistics you look at. It's considered a pretty big problem. The chronobiology researchers at the University of Minnesota have given me essentially not a solution, but a way to attack this problem in the form of chronobiological interpretation of blood pressure variability. It goes beyond typical blood pressure measurements, even going beyond ambulatory blood pressure measurements, which doctors will sometimes use. Specific results that come out of this chronobiological analysis will actually help identify individuals who are at risk of stroke and risk of cardiac disease events over the next few years. That gives you the chance to treat them preemptively, which of course makes a big difference if you could treat people before they have the problem rather than after the problem. It changes their situation and changes the cost of healthcare overall quite a bit. So we have this kaboom concept, which is a somewhat humorous attempt to pronounce CABPM. CABPM was the chronobiological ambulatory blood pressure monitor that we think is the answer to identifying these individuals that are at risk of stroke and cardiac events. We're aiming to build a consumer device, something that people are going to be using at home, so this is not necessarily a hospital or clinic kind of application. In fact, we will build a lot of consumer devices, meaning a lot of different models with different characteristics. At the bottom of the slide are our 3 basic requirements that we're always trying to meet. When we say inexpensive, we mean really inexpensive, almost disposable to some people. We have a cute phrase for this too that we use, which is, at least for developing countries, we want the cost of this thing to be less than 2 bushels of yams, to get it down to something that everybody feels that they can afford. It needs to be unobtrusive or people won't wear it. And it needs to be easy to use so that they don't goof it up while they're at home alone trying to run a medical device. We came into this conference with a fair number of prototypes of sensors to get blood pressure without using the cuff. We're pretty sure we have to get away from the cuff to meet some of those requirements like the unobtrusiveness. And there's several techniques and several technologies that you combine together and try to build devices from. Our design sessions here, though, we've gone to trying to model the actual products that we would sell with their different variations. These variations are going to be important in the marketplace for product differentiation and targeting different segments of the population. So we're building up with this activity, we're building up a portfolio of user scenarios and models of blood pressure measurement devices that go along with them. And so we're going to go through several of them here. Our Band-Aid patch is the first one. This is one we actually envisioned very early on in the Phoenix project. We assume that people can wear a patch for a few days at a time, which is kind of the minimum requirement for getting started with this chronobiological interpretation of blood pressure. It's going to have some wireless communication abilities in both directions, meaning not only does it ship the data off wirelessly, but it's going to be controlled by some other device. And so there's no real user interface on the patch itself. The patch should be able to be compatible with multiple arteries, carotid artery, shoulders, and there's wrists and elbows and ankles and all sorts of places you can do this kind of thing. But it has this problem where it's difficult to place. So our first idea was that physicians might train users or wearers of this kind of device, and then perhaps give them a customized template to help them remember or how to place the device on themselves after they've left the physician's office. So this little storyboard kind of thing is part of our portfolio of user scenarios that we are building up. There's a patient visiting a physician over on the left and getting trained. The big yellow tag is the positioning device. And of course, it's this low-quality prototype that we're working with here. Okay, another device is the sleeve. Can somebody show the sleeve? This has a similar positioning kind of problem, but we solved it with a registration mark at the elbow. So no real training should be involved with this. It should position itself. The sleeve has other problems like getting dirty and needing to be washed, so we put a removable display on it to make it an easily washable item. Let's go into the rings. We're starting to get into the sort of the vanity features that some people will need to be attracted to wearing this kind of device. The ring solves some of the bacteria cleanliness problems also. Is that a cell phone or what is?
That's your time's up.
Time's up? Oh, okay.
You can wrap up here. Just let's get to the.
Yeah, there's two or three of those, and so like I said, we've built up this portfolio. The next things we know we need to do is go back and do some of that sensor research because it's not really done, and then we want to do iterative demonstrations. Excuse me, iterative demonstrations with users or representatives of users to get more ideas for more models and more user scenarios. And we're getting close to the point where we would actually consider manufacturing partnerships with people, because there are some of these that are just about ready to go through the final R&D phase and get into the manufacturing step.
Thank you.
Hi, my name's Nancy Paris, and the point-of-care antibiogram exercise we did was with Stephanie Kreml and Brian Burkhart and Ryan Kannikin. Oh, and they're here. Yay. Brian had to leave early. How do I move this forward? So the challenge is really one that the WHO has stated as a priority area. So infants 5 and under, mortality rate is still quite high in low-resource settings, and gastrointestinal illnesses are deadly, and that's basically what we're trying to find a solution for. Antibiogram tests can determine what is causing the illness if it's a bacteria-caused problem, and once you know what that bacteria is, you can prescribe an effective antibiotic, and what's happening right now is it's sort of like, well, we think you have this, and here's 6 antibiotics, if they can get antibiotics at all. So that's contributing to antibiotic resistance, which is very scary globally as well. One of the problems is that the antibiogram tests are conducted in the laboratory setting, and as we've all heard, for those of us that attended the global health sessions today, there just aren't enough laboratories around the world to make this stuff possible. And a lot of the times they're just too far away, and particularly in developing countries, if a family has more than one child and one child's sick, the mother can't leave with the sick child. So there's a lot of reasons to bring the technology into the rural setting or the developing country setting. And that is what we're proposing to do. So essentially taking the antibiogram test from the laboratory setting and turning it into a point-of-care test that can be used in low-resource settings. So this involves developing a portable system that can be carried from a lab to a low-resource setting. And a backpack is obviously one option for that. So the technological platform at this point, we're really just looking at using existing microbiology antibiogram tests. So that test is the same. The real innovation is in miniaturizing the system and some of the graphic user interface issues that we looked at yesterday during the exercise. We do have a medical laboratory scientist looking at a molecular test, but at this point, even if that happens, in either case, you still need a system to be portable and to be able to be transported into a low-resource setting. So during yesterday's exercise, we did get to some prototyping. The group I work with at home at BCIT does run through a similar process, and we'd already had some concepts developed, but yesterday's team helped further those along. So Stephanie came up with this wonderful portable backpack that also has some features in it, like a table that might fold out of the backpack. Just various features that you have to think about when you're a single lab tech or possibly just a nurse without real lab training, but that can be trained up to use the system. And you're coming into a low resource setting, and there's up to 15 tests that could be administered. So you've got 15 different kids that you're going to be testing alone in a low resource setting. You've got to think about that for a second and try and put yourself in that scenario. What might you need to be able to do that sort of a test effectively? So some of the features here were just integrating a table, and that was one concept we hadn't come up with. Also, just looking at basically the test requires a cooler and an incubator, as well as the microbiology test itself. And if you can imagine growing, let's say, E. coli in a low resource setting, and you've got a bunch of petri dishes or with E. coli growing in it, you definitely need a way of taking all that back with you or disposing of it responsibly, because you don't want to create a bigger problem than you're trying to solve. So lots of different issues. So there's sort of a part of the test that you'd bring back to the lab and reuse, and a part that's disposable or consumable. This is another really interesting part. We don't want to provide a booklet of instructions and a booklet of ways of keeping track of kids. This has to be very easy to use for the lab tech or the nurse that's administering the test. We're also hoping to develop it for a global market, so we don't really want to be translating it into 20 different languages. So just looking at what other products out there that you use have really good instructions. So things from IKEA, things from Dyson, things from Apple, where they're very illustrative. There's a few words, but it's very clear and easy to use. We looked at different ways of matching the child to the test. There's several petri dishes of testing that needs to be tracked back to a single child. And some of these could be babies, newborns, so it's not exactly easy to tell people apart when they're that young. So we talked about wristbands or temporary tattoos. We also talked about using checklists, just using some of the things that people use nowadays in developed countries, and applying those very simple things to this product. And then in our ultimate, because as we all know, cell phone technology is everywhere. Even if you don't have much else, you probably have a cell phone or the ability to use one, then it is possible to develop the system so that the lab tech or nurse has a smartphone and can call back to the lab setting with the test results and possibly maybe even a photo of it, just to confirm that it is the bacteria that they think it is. And then the medical person can say yes, then use antibiotic X to treat that bacteria. So QR codes were discussed as well as a possibility. And there were many other great ideas that we weren't able to capture, but I've got them all written down and we'll be taking them home with us. This was one idea where you just, use friendly looking stamps possibly instead of names or numbers to help identify patients. This is our team back home. We're also partnering in with a company in Chile that's interested in UTI, point of care technologies for developed countries. So we're trying to look at this as a marketable product. We really don't want to develop an idea that stays in the lab. We need the supply chain right through so that the product can be used. Thank you very much.
Good afternoon. Thanks so much to IEEE and IDEO, to the chairman, organizers. It's a great opportunity for us to come together. This is our team. My name is Ji Wu, and Javier, and Paul, simply, and Sarah. Actually, we have Santos help us a little bit. So our topic is about the business model for telemedicine. Today the challenge is we identify the senior people and some chronic care patient is very popular in the world today. I just checked, there are 246 million people have diabetes in the world, 200 million. In states, it's 28.5 million people have diabetes. And there are about 18% of states is more than 65 years old. So all these kind of people need more care. In the same time, they want to be independent. And their family and the people want to provide care, and how the doctor can help them. This is the challenge today. What should we do?
Yeah, so but right at the beginning of the whole process of the IDEO, we didn't start from scratch. We were quite focused on the technology. So you came with this great telemedicine technology. So, but we didn't know really what to do with that. So who's going to pay the service? Who's going to be the target population? Who's going to be the rural area? How we are going to interconnect those people? So we started within this 2 hours, 2.5 hours time. We gave more importance to what type of applications we can derive from this type of technology. What are the images, or what's the information we can take of it? And as we were still working on that, we think we progressed and gave more information to the key point of it. So what are the agents? Who's going to benefit from it? What are the end users? And what are their requirements? So from this perspective, we could focus much more on how to satisfy those requirements. So it is simply a change of perspective from a technology-based point of view, from a human or social-oriented point of view that made us understand what our technology was capable of.
So if we don't have a dashboard, right, you know, the solution is, okay, you present a whole bunch of information to the user or to the technical person, and then they will help make decisions, right? That's how we started out. And then we ended up by saying, well, no, we want to enable more people to get better care. And so nursery is kind of a play on words, right? Nursery. So nursery is the technology that connects these three groups of stakeholders together. The patient wants independence, but with medical supervision, so they feel confident in living independently. The caregiver gets notification about when they should pay more attention to their family member or to the patient, and the physician in the healthcare service is constantly kind of they've got alerts set up, they've got mechanisms to tell them when the patient is doing well and when the patient is not doing well. So the information is kind of combined together and integrated and then communicated in a seamless fashion. That's why all the arrows are two ways. And what we'll try and do is we'll you know, instead of going through a lot of slides, or a video, because we didn't have enough time, we'll do a little mock skit, okay? And to show you how this might work. So there's an alarm. Nursery says, oh, okay, you need to do your blood test today, or you need to take your pill. So in this case, you know, we know cardiovascular disease and diabetes are very large problems. A large number of patients are affected. So in this case, we get an alert. The patient gets an alert. Then once the alert is there, then they will do their test. So did you do your test? You do your test. And then we get to the next screen where there we got our caregiver is informed that the test was done, okay, and they know, oh, okay, the test was fine today, and then there's no problem. But then the doctor gets their own screen immediately informed by nursery, and in this case they find out, okay, it's been 5 days where the blood pressure has been high, okay? And so automatically, even without the physician having to turn their attention away to what they may be doing, an alert is sent back to SRI, okay? So that's why, again, the links are two ways. An alert is sent back to SRI, and nursery says, okay, I need to schedule an appointment because the doctor's already set up this filter for this patient-specific filter, and nursery then goes ahead and informs both the patient and the caregiver that now we need to set up an appointment. And now, nursery gives some feedback.
Well done, John. Now is the time that you set an appointment with your doctor, but continue monitoring yourself.
Thanks so much. So for next step, we will try to do more customer investigation to segment our market and to define a different function for different customer requirement. That is short term. For long term, we will to define the standard compliance like the language support, all these kind of things, and the more design job and engineering work and implementation. Our team want to continue this project for a while. So that's all. Thanks so much. Thank you.